I'm Karen Reedy. I am the occupational therapist that works on the first floor in outpatient. I also take care of our healing center patients. My lovely partner in crime in the striped shirt is Andy. This is my OTA. And then Amber is my OT student right now because we are a teaching institution, so we pass it on. Yay! So we are Team OT. And we're going to come here today and talk about the role of occupational therapy in chronic pain management because, well, that's what we do. So if I don't work with you every day or several days a week, what is it that an OT does? Anybody? And the first person to say I find you a job owes me their donuts. Ruth.
Teach people how to do things properly in their everyday living.
Yeah, that's a really good 50,000-foot view. Most people say, oh, you find people jobs, or you get people dressed, you help people shower. That's a lot of what we do with our healing center patients. But our areas of occupation, which is the things that we do, the things that you do to occupy your time every day, not just your job, but you're getting dressed, you're being a parent, you're being an employee, you're being a family member, all of that touches on OT, and all of that is stuff that's impacted by chronic pain management. So before you leave today, if I'm successful, what I want you to do is to be able to describe the impact of chronic pain on people's occupational performance, not just in terms of their job performance. And then to be able to look at a patient and say, hey, this might be, something that OT can help them out with. Beyond, I fix broken hands, I fix broken shoulders, he can't wipe his butt, he can't get dressed, let's send him to OT. There's more to us than that. So the best approach for chronic pain management is a biopsychosocial approach. When I do an evaluation of a patient, I look at the biologic factors of what's affecting their pain. I look at the psychological factors of how they perceive their pain. I look at their social support system. And all of that rolls into how that patient perceives pain. And this is all stuff that we probably all know because this is what we're doing every day. But patients with chronic pain in the U.S. have more per population, the total number of people with diabetes, heart disease, and cancer combined. It costs us, in terms of lost production, medical use, more than $500 billion with a B per year. And anywhere from 4 to 7%, depending on the studies that you read, report experiencing daily pain with the use of opioid pain medication as their first line of pain management. And as a lot of you know, in 2016, the CDC changed the way that we're going to be looking at and using opioids. I was at a clinical at the VA at the time, and it was a big deal. The very first one was the biggest deal because they recommend no concurrent use of benzodiazepines with opioids. So a huge percentage of our veteran population was going through the VA. Okay, here's your, tramadol or your trazodone rather to help you sleep, and here's your Vicodin to manage your pain. And oh my gosh, why are you all dying of respiratory failure? This is kind of a big thing. Increased caution monitoring when prescribing for patients with mental health diagnoses. PTSD, depression, anxiety, all kinds of stuff like that needs careful monitoring when you're using opioids. They're now emphasizing function as the primary goal, not just pain reduction. So yes, you can still do all of these things. You can still do them better, even though you're still experiencing some pain. And then they're also recommending increased use of non-pharmacological treatments for pain management. Hi, that's me. That's also PT. So as we said, the biopsychosocial model is one that we use to address pain and disability in OT. It is the most widely accepted, the most evidence-based approach. My husband, the social worker, also uses it in his evaluations. Basically, it views pain and disability as a complex and dynamic interaction among physiologic, psychologic, and social factors that perpetuate and may worsen the clinical presentation. So it's not just pain in terms of, ow, I hurt, but it affects everything about that person. And the doctors here know that I speak about this from a very personal perspective because my husband has been a pain management patient for 5 years of Dr. Aldahiri's. So I take this home every night. My husband, Greg. I was teasing Ruthie. I said, more of you guys probably know me as Greg's wife than as the OT who works on the first floor. So, physiology of pain. This is an entire field of study in and of itself, but in a really small nutshell, the body reacts to a stimulus, processes a neuroresponse to do something. When I'm out having lunch with my very pregnant cohort here and the server tries to take her tray away prematurely, she stabs them with a fork. They say, ow, and drop the fork. That's a pain response physiologically to her stabbing them. Psychological perception of pain. There's so many moving pieces here. The context, Is the patient in pain in a hospital, at home? Is it affecting their ability to go to work? The attention that you give to that pain, it's like when your toddlers first learn to walk and they take that first fall. Do you go, oh my God, and you lose your mind, and then the child melts down? Or do you wait and see, do they shake it off? Are they going to stand up and walk and be okay? The fear or anxiety about the pain, the sense of loss of control. How much has this patient lost or not able to do because of this pain? Ideas of how much pain should be present. I go through this one with my mom. She had shoulder replacement, and she figured she'd be, sailing through and she'd be okay and back to her regular everyday function at 6 weeks. I had to really try hard not to giggle a little bit and say, no, you're 65 years old. Your shoulder was destroyed, which is why they're replacing it. It's going to take you a lot longer than that. Personal beliefs regarding pain. Is it macho? Is it, cool to be in pain? Is it, wimpy to be in pain? How much attention does it give me? How do we cope with it? Your sense of self-efficacy, your locus of control. Is this something that the world has done to me, or am I in control of this situation? Can I manage this pain myself? Am I afraid of this pain? Is it making it worse because I'm feeling it and I'm scared it's going to hurt if I move it? Therapists, we see this all the time. I don't want to do therapy because therapy hurts. The more you do therapy, the less therapy hurts, the better you get. People wrapped up in the identity of being a sick person. We've all had that patient that is very, very dramatic about their illness or about their injury and the attention that it gets them, and it suddenly becomes the center of their world because they have a broken finger. And to that person, that is the center of their world, but the rest of us can move on, and that's the kind of person who tends to catastrophize and make the worst of every possible situation. I like to look at best case scenarios. Not everybody is as enthusiastic. Social factors, socioeconomic status. This is really important for us here in Flint because there are numerous studies that show that folks in a lower SES do experience pain more acutely. They report higher levels of pain. Has nothing really to do with race or color. It's just your everyday living situations, which focus in with your cultural beliefs, your social supports. How much is your family there or not? Your unhealthy lifestyle. This is all stuff that we see every day as comorbidities, substance use disorder, family issues, conditioned pain responses. We're back to how much attention do you pay to someone who's in pain, and do you reinforce that behavior? So here's one of your objectives. Chronic pain can result in decreased participation in occupations of self-care, your ADLs, your bathing, your grooming, your work, your sleep, sexual activity, and mobility. That doesn't mean I want to see everybody down an OT that reports having, a dissatisfactory sex life. That's not quite what I'm here for. Also impacts role performance, such as, being a parent and bringing up those kids, socializing and playing. We have a patient now in the Healing Center that we are advocating to get him a standing wheelchair because he is now paraplegic after a car accident. He's got 4 kids under the age of 6. So he's going to have to be able to get things out of high cupboards to get those toys that he put away, or, to be able to pick up the kids and get up and down curbs, in and out of school, stuff like that. And his perception of pain is going to affect that, and his ability to play with his children. So 2/3 of people alter their activities to maintain participation while they're managing their pain. And you might have somebody like a father with chronic pain who's going to go to his daughter's basketball game. He's very concerned about the fatigue from being at work all day as a construction worker, so am I going to have the energy to go? He has low back pain, so is he going to really want to sit on those wooden or metal bleachers without any cushioning, walk up all those stairs, embarrass himself standing up to relieve his pain in the middle of the game, draw attention to himself, have his daughter go, oh my God, Dad, I saw you standing up. And so they decrease the frequency of the performance. He might not go to as many games. They decrease the quality of their performance. How much attention is he able to pay while he's there? Delegation of tasks. He can't go to the grocery store anymore, so the wife does the shopping, the kids do the shopping, or they stop doing it altogether. And if and when participation does continue, people are frequently not satisfied with their performance in a task. He might not go to the game because he's like, well, I'm going to just, when I have to get up and take a stretch break, I'm going to miss her big shot that she won the game, or I'm going to be too tired to go after work. So it becomes kind of a give and take of how much of the rest of your life do you give up while you're managing that pain. We all know about the physiologic changes. That's usually why people send people to Erica, good old-fashioned therapy. Decreased strength, range of motion, stability or balance, motor control, proprioception, your knowledge of where your limbs are in space, My dogs have absolutely none of, which is why I have all kinds of bruises, because they walk full into me. My children, the same thing. Also recruitment, how we manage tasks. Does a person with a hemiplegic shoulder reach up for things? No, because they have a hemiplegic shoulder. The chest comes up, the shoulder comes up, and you see a lot of this, which results in spine and back pain as they're trying to get that arm up to get that extra movement. Coordination, endurance, speed, any changes due to like the guarding or their change in patterns of movement. Cognitive changes. I see this one a lot at home. I saw this one on Monday. I came home and said, hey, they asked me to do grand rounds today. I'm going to talk about the role of chronic pain management with OT services. And my husband, meantime, is thinking about how much his back is hurting, and he had immediately asked me for a back rub to help manage the muscle spasms. I said, okay, fine. So I'm giving him his back rub. I said, so I had an idea that he wasn't really listening to me because that look in his eyes that was distracted. I said, do you remember me telling you that I was going to do grand rounds this week? He goes, yeah, what topic are you going to present on? I'm like, I mentioned that. So you have decreased memory, decreased attention. He attended to my conversation long enough to hear me say I'm presenting, but not the rest of the thought process.
That's just a male thing.
It is, but it's worse when he's in pain. I can always tell when he's in pain, but yes, it is. You're not wrong. Decreased executive function, problem solving, rationalization decreases when you're in pain. So, Dr. Shaw, I'm glad to see you're not in pain this morning.
Doctors have this problem too.
Oh, absolutely. We all do. Psychological changes, the pain cycle that you're in, you're not getting the pain resolved. People start to tell you it's all in your head. You can't find a source for it. So you feel helpless. I can't do the things I want to do. I can't be a father to my kids. I can't do the grocery shopping. I can't go to work. Worthless. It's not going to get any better. I've been to 10 doctors. Nobody has fixed this problem for me. You start to really feel hopeless. And the longer the pain persists, the worse the feelings get. And then you get more into those negative outcomes. It becomes a really, really big, ugly snowball. So you increase your fear and anxiety related to pain because you don't want to get hurt worse. You get increasing depression because you're stuck here. You don't see a way out. So it all comes compounding down, which leads to fear avoidance, or as one of my patients likes to say, that the big $5 word is kinesiophobia. It's fear of reduction or movement due to fear of re-injury. How many of our back patients, knee patients, shoulder patients, I don't want to do that anymore because I might get hurt again. Overall, you decrease your activity. And this is a really wide number, but I'm going to throw it out there anyway. Between 24 and 58% of adults with arthritis are physically inactive because it hurts. You know, they can't figure out a way independently to find a way to move that doesn't hurt. My mom took probably 5 to 10 years to figure out that aquatherapy is great for her knees because then it doesn't hurt. But that's because her physical therapist suggested it. She wouldn't have come up with that one on her own. So we all have value. You know, people give up cooking because I can't stir anymore because it hurts. There's adaptive equipment that we can prescribe in OT that will help that. Social impacts, emotional changes in family members. Your spouse gets upset because you don't remember things because you're wrapped up in your pain. Decrease in socializing. It hurts too much to go out. I don't want to be distracted. Everything comes rolling back in. Financial changes. It hurts too much to sit at my job and go to work every day. All I can think about is how much pain I'm in at work. I can't pay attention to my patients that I'm supposed to be talking to and helping through their problems because I'm so wrapped up in my own. So basically, social interactions become increasingly difficult, leads to avoidance, leads to social isolation, which leads to a whole other set of psychological problems. So, how can I help? How can OT help with chronic pain management? Self-management strategies. The more we can teach the patient to be in control of their own pain and to come up with their own strategies, implement their own ideas, improves pain management, improves mental health, improves health-related quality of life, which is a big benchmark. Our goals aren't necessarily reducing pain. Our goals are to improve functionality with the existing pain that you might not be able to get rid of. This might be a long-term condition. We have to deal with a little bit of pain, but we have to find the way for you to function as best you can working around it. We use occupation-based interventions. So you're having pain when you're cooking because your wrist hurts because you have carpal tunnel, Or, your back hurts because you can't stand that long. Okay, let's look at ways that you can meal prep sitting down. Let's look at different ways that you can hold things or move things that will allow you to get back into the kitchen and do those valued occupations. And let's have you problem solve along with me. So what if you held the spatula like this instead of whipping it like this? Does that help you? Let's practice that in therapy until we find a solution that works for you. So basically, we get the patient back into all of their parts of living. We increase their participation in all of their valued occupations, not just their job. So we use a variety of methods, and cognitive behavioral therapy is one of them. That focuses on decreasing the maladaptive behaviors, the pain displays, the wincing, the over-dramatizing of your pain symptoms, the avoidance. We help you kind of recognize some of those negative thoughts and find ways to deal with it. We do pain education. A lot of people don't know what causes pain other than, ow, it hurts. So let's look at ways that you can reduce the pain biologically. Is it deep breathing? Is it, visualization? Is it mindfulness? Is it biofeedback? Can you look at that pain and help to bring it down without drugs? Coaching. There's a whole field of occupational therapy based around lifestyle redesign. That sounds like a 1960s hippy-dippy commune type term, but for people that want to lose weight, for people that want to quit smoking, for people that are working around major joint replacements, that's a lifestyle change. It's not just I go to therapy, I take my drugs, and in 6 weeks I'm poof, magically better. That's not what we do. There's got to be weight loss. There's got to be eating changes. There's got to be increase in exercise. And if you just sit down and look at that, that is a big, big thing to say, oh, I have to do all of this. I can't. So I'm just going to sit right here. I'm going to stay here. I'm not going to do my home program. I'm going to get worse. And all the doctor's efforts, all the therapist efforts are going to be in vain in 6 months because you're going to be right back to where you were. But sitting down with an OT, we can start looking at small goals that we can get to. Let's look at little changes. Let's this week work on keeping a food diary. Let's look at how we can improve your eating. Great, you've done that for 2 weeks. Let's work on how we can get more active. Let's find some aquatherapy classes for you. What about walking? It's a whole series of little changes that lead up to one big overall improvement in health. So we take on the role of more of a health coach. We talked about relaxation training. Activity pacing is a big one. There's a story about a veteran who will go out, and he was all excited because he could still cut his grass on Saturday after he had his back pain addressed by therapy. Okay, great, but then he spent the next 3 days in bed because it was so overwhelming. The pain was so bad. But I can get it all done in one Saturday. It's only one day. But working with a therapist, we said, okay, what if you cut the backyard on one day, the side yard on another day, and then the backyard on another day? You do things in little chunks where you can still function and still have your life afterwards, and you're not just completely blowing all your energy on one task.
You're working all the time.
You're working for a half hour versus 4 hours and spending 3 days in bed. So that's also a guy thing. All the groceries in one trip or not at all.
Say, but they're working all the time, doctor.
We also talk about work-life balance in occupational therapy. Social interventions. We address those pain behaviors. OT, I say it all the time with our healing center patients, but it's true with all of our patients. We don't just treat the body in front of us. We treat the entire family. So, if someone is having those pain magnifying behaviors that, oh, my back hurts too much to get off the couch today. Honey, I can't go grocery shopping. Honey, I can't help you put the groceries away. And then it's, oh, sweetie, it's okay. You're in pain. You don't have to do that. He's got an out. He now doesn't have to unload the groceries or help with the shopping just because he says he's in pain. He is conditioning his wife to that behavior. So we can look at the family and say, okay, well, you feel like you can't get off the couch. How about if you sit down on a chair and you can put away the cans here? You can put away the stuff in the fridge. There's ways that you can help and you can participate. So we train the patient to be physically present and participating in their own life. We help subtly, politely train the family not to cater to those feelings of helplessness. Amber, how many times have I used the phrase learned helplessness in the last 4 weeks?
Specifically with one patient.
We can also facilitate socialization. Even if it's just setting a patient up with a blog or an online diary, because patients who blog about their pain, just to get it out there It helps reduce their perception of the pain, helps reduce their feelings of isolation, because there's somebody out there, there's somebody listening, somebody talking. That doesn't mean you need to have the negative Nelly Facebook page. Every time you have a twinge, you got to post about it on social media. But at least that way you have an outlet. Your spouse isn't the sole brunt of all of your negativity, and that's all you talk about, which we have that conversation a lot too. It's time to talk about something more than your pain. There's more to life. Physical interventions, good old-fashioned therapy, positioning, body mechanics, physical activity training. The more active you are, the less being active hurts, believe it or not. And then relapse prevention training. You're going to have a bad day. Not every day is going to be your best day. Not every re-eval is going to be your best re-eval, but that's okay. Here's how we deal with the pain that's inevitably going to come. You ice, you heat, depending on where it's at, what you have going on. You use your TENS unit that we're going to teach you how to use. And you deal with that day, you turn the page and move on, and your next day starts over fresh. So that dad who doesn't want to go to the daughter's basketball game because of the hard bleacher seats, take a little cushion to sit on. Sit in the back row of the bleachers so you can pace, without disrupting the game. Or, sit right by the door so you can stand up and walk in the hallway but still have yourself, as part of the experience of the game. So there's different ways we can do it. So what? So going back to the guidelines on opioid use. No concurrent use of benzodiazepines with opioids. So what? I help facilitate rest and sleep through non-pharmacological means. We can talk about relaxation. We can talk about meditation. We can talk about white noise. We can talk about progressive muscle relaxation to help you get to sleep without so much trazodone. Increase caution when monitoring and prescribing for patients with mental health diagnoses. That's what OT started as, to help restore mental health and functionality and quality of life to wounded World War I soldiers 100 years ago. We've been doing this for a minute. We emphasize function as a primary goal, which can improve even with pain. We focus on managing that chronic condition to increase your function. Our goal is not to manage your pain. Our job is to help you get your life back in spite of the pain, around the pain. And then last but not least, we increase the use of non-pharmacological treatments for pain management because we are a non-pharmacological treatment for pain management. So occupational therapy helps with more than broken shoulders, broken hands, people who can't do their ADLs because of a brain injury. It's somebody that, has chronic pain that doesn't feel like they can go through their everyday life the way they would like to. So not to be whiny or complainy, but in the last 11 months that I have worked here, you guys in pain management have sent us less than 10 patients to OT. We could have a whole lot more impact on a whole lot more of your patients, I feel. Even if it's just 1 session, 2 sessions, to say, hey, as part of our evaluation, how are you coping with your pain? How are you doing with your activities of parenting, of familying, of grocery shopping, of managing your bills, of remembering that you've got an appointment to get to before the reminder phone call comes from IINN. You've got an appointment tomorrow, and you go, oh crap, I don't have a babysitter. All the little pieces that make you you that are not as you when you have pain. Those are things that we can find different ways to help with. One of my patients affectionately calls me MacGyver because of the off-the-cuff solutions we come up with just to try different things. Well, thank you guys. I hope you have a wonderful rest of your day.